Very good morning, ladies and gentlemen, and welcome you to the Sri PD program, which is organized by the Society for Health Research and Innovation. And joining with us today is Dr. Vasudevan. So I'm very privileged to introduce Dr. Jyothi Vasudevan, who is an associate at Mahandi Medical College and Research Institute. And Dr. Vasudevan is an experienced medical education and research with over a decade of experience in teaching and postgraduate medical training, along with very substantial clinical experience in cardiology. So her areas of academic interest include adolescent health, non-communicable diseases, community-based interventions, and also medical education. So she has been the recipient of several prestigious academic awards, including Dr. M.V. Kulkarni Prize for Excellence in Maternal and Child Health Research, and multiple first and second prizes at national and state level scientific conferences, and also top national scores in postgraduate diploma at MPTEL ICMR courses. And she has also guided several ICMR funded research projects and has published extensively in reputed national and international journals. So Dr. Vasudevan is also actively involved in curriculum development, in institutional quality assurance, and faculty development initiatives. And we are honored to have her here with us today. And we look forward to an insightful and an enriching lecture. So over to you, Dr. Jyothi Vasudevan.
Hi, good morning to all of you. And I sincerely thank the Sri and all the organizers for this opportunity. And thank you for joining the CPD webinar and also for giving me this opportunity. And today I will be speaking on integrating public health perspectives into everyday clinical practice. So this session is designed for clinicians across specialties, and the focus will be on how simple public health principles can be applied realistically within routine clinical care. So I'm looking forward to an interactive discussion, especially during the question and answers session. And before we begin, I'd like to briefly outline the objectives of the session. So by the end of this talk, we aim to understand how public health principles can be integrated into routine clinical practice. And I will also be discussing how to apply simple WHO tools for opportunistic screening and risk assessment, and how to deliver brief, effective lifestyle counseling within limited consultation time. And we'll also look at how continuity of care can be strengthened through appropriate referral and follow-up. Now, this is actually how the session is structured. We'll kind of begin by discussing why public health matters in everyday clinical practice. So then we will move on to rethinking the clinical encounter through a public health lens. Then this will be followed by practical strategies to strengthen preventive care. And we will also touch upon patient communication and community-oriented approaches for continuity of care. And finally, apply these concepts through simple case scenarios before concluding with key takeaways and discussion. So, why integrate public health into clinical practice? So, non-communicable diseases now account for a major share of morbidity and mortality. Yet, many risk factors remain undetected until complications develop. In routine practice, our focus is often on treating the presenting illness, while opportunities for prevention are easily missed. So public health reminds us that even small preventive actions taken consistently during routine encounters can have a large impact at both individual and at the population levels. So integrating prevention into clinical care is that not optional. It is actually very essential for improving long-term outcomes. So in our daily practice, there are several common missed opportunities. For example, in a busy OPD, the blood pressure may not be checked during visits unrelated to hypertension. For example, if we get an adolescent who presents with a fractured, simple small fracture, like maybe a fractured finger or something. So, and lifestyle risk factors such as tobacco use or physical inactivity or even diet may not be routinely assessed. Preventive counseling is also mostly postponed due to time constraints, and follow-up planning may be inadequate once the risk is even identified. So please remember that these are not failures of intent. They just reflect system pressures, but they also highlight why prevention needs to be consciously built into the routine care rather than treated as an additional task. This brings us to an important concept in prevention, which means that every contact counts. So in other words, every interaction with a patient, whether it is in the OPD or ward or a follow-up visit, is an opportunity to identify risk and also provide brief advice or reinforce health. Patients may come with one complaint, but they might even carry a lot of multiple underlying risks. So the idea is not to convert every visit into a long counseling session, but to use each contact purposefully. For example, screening for risk factors, patient education, and also brief counseling, and also to plan follow-up. So this actually should be possible when we have a shift in the approach. So traditionally, clinical encounters follow just focus on diagnosing and treating the presenting illness. So this approach is correct, especially in acute care. However, there is an emerging need to identify future risk early. That is, even before the disease develops or complications occur. So clinical care and public health are not separate, they are complementary. Importantly, prevention can be integrated into routine practice without increasing consultation time. It is actually more about what we prioritize and not how long we spend. So there must be a shift from episodic care to risk-based preventive care. So this slide highlights a shift from the disease-centered care to risk-centered care. So actually, the disease-centered care asks, what is wrong now? Whereas the risk-centered care asks, what could go wrong in future? So by now coming to the disease-centric approach, it just treats the existing illness. It is symptom-driven and focuses on short-term outcomes. Whereas the risk-centered approach identifies future risk and is opportunity-driven and has a long-term health impact. So by identifying and addressing risk factors early, we move on from the episodic treatment to anticipatory care. So this shift is particularly important for chronic diseases and long-term outcomes. Again, to emphasize this point, disease-centered care just focuses on diagnosis, treatment, and illness, whereas risk-centered care focuses on screening, assessment, and prevention. So this actually, captures the essence of preventive care, that is, managing risk today prevents disease tomorrow. So when we manage risk today through small, consistent actions, we reduce the likelihood of disease tomorrow. So this applies across conditions, age groups, and across specialties. So prevention is therefore not theoretical. I mean, it is not abstract or, kind of theoretical. It is a practical clinical strategy. Now, coming to the foundation of prevention. So one of the most effective ways to integrate prevention into practice is through opportunity screening. So screening during visits for any health concern, and it does not require separate appointments, is especially important in asymptomatic individuals. Please remember that this involves checking key parameters during routine visits, such as blood pressure, calculating the body mass index, or measuring the waist circumference, asking about tobacco and alcohol use, and also looking at the relevant family history. So what I'm trying to emphasize is that these assessments do not require special appointments. They can be incorporated naturally into existing workflows, and it often takes only a very few minutes. So coming to what should we screen? So the WHO STEPS approach provides a simple framework for identifying major non-communicable disease risk factors. For example, it focuses on behavioral risks like tobacco use, harmful alcohol use, physical inactivity, and unhealthy diet, as well as physical measurements such as the blood pressure, height, weight, calculating the BMI, and also emphasizing waist circumference. Using such structured approaches helps to ensure that screening is systematic rather than ad hoc. So why steps? Because it is standardized, evidence-based, and globally accepted. So the steps is actually, a strategy for identifying the prevalence or how huge the risk or the problem is, and therefore we'll have an idea of how much resources to put in and what exactly needs to be prioritized and managed. So this is especially important in countries like India and Sri Lanka, because we are developing countries with limited resources. And the thing is, in practical situations, why risk-based screening matters? Because not all patients have the same level of risk. And as I said, resources and time also are limited. And risk stratification will help us to prioritize high-risk individuals, guide intensity of intervention, and also efficiency of care. So instead of treating isolated numbers, we look at the overall risk profile of the patients, and this allows for more targeted counseling and better use of resources and more meaningful preventive interventions. And moreover, it helps to identify individuals who may appear asymptomatic today but are at high risk for future diseases. So now this is where the WHO risk assessment tools become essential. So we have discussed why prevention matters and how risk-based thinking fits into routine care. So now, to support clinicians in private practice, the WHO has developed simple practical tools that are designed specifically for the real-world clinical settings. So in today's lecture, we will briefly be touching about a few of them, which is the WHO PEN, which is the Package for Essential Non-Communicable Disease Interventions. It's an acronym. Next, we will be talking about the WHO HEARTS. That is mostly, it's a technical package for cardiovascular disease management in primary healthcare. And it focuses more on healthy lifestyle counseling. And of course, we touched briefly on the WHO steps. So this has actually, 3 steps. 1 and 2 are especially important for low resource settings. Step 1 is collecting the proper prevalence of risk factors by specific questionnaires. Step 2 is adding physical measurements to that. And these first 2 steps are more important for knowing how widely prevalent the program or the problem is. And step 3 is not really applicable to low resource settings because that involves biochemical measurements, like cholesterol levels, etc., which might not always be feasible in setup like ours. So add on to this are WHO cardiovascular disease risk charts. So that will help in risk stratification. Again, there are 2 types of risk charts. We'll be talking about that also, like lab and non-lab risk charts. And finally, to complete the loop, we will be talking about brief counseling models and with special emphasis on the 5A model. So coming to the WHO PEN, the WHO PEN package focuses on essential interventions for the prevention and management of non-communicable disease at primary care level. So this is providing practical algorithms for conditions such as hypertension, diabetes, cardiovascular diseases, and common lifestyle related risk factors. So for clinicians, the strength of the WHO PEN lies in its simplicity. It offers clear step-by-step guidance that can be integrated into routine care without complexity. In other words, there are practical algorithms that can be used in busy clinic, and it covers a range of non-communicable diseases like hypertension, diabetes, and cardiovascular risk. So here again, the emphasis is on opportunistic screening, risk-based management, and brief lifestyle counseling. From a clinical perspective, WHO PEN supports early detection and standardized management and also continuity of care. So this makes it particularly useful in busy outpatient and primary care settings, especially which are resource limited, because it emphasizes task sharing, simplified decision making, and regular follow-up. And more importantly, it aligns preventive care with existing clinical workflows rather than creating parallel systems. So what's a clinical advantage? It helps us to standardize care without replacing clinical judgment. Now, we will just discuss very briefly about the WHO HEARTS. So the WHO HEARTS is a technical package which focuses specifically on cardiovascular disease prevention. So HEARTS is, an acronym, and it stands for healthy lifestyles, which means health promoting activities for risk factors. And it has a set of evidence-based protocols, which are simple standard algorithms for the management of hypertension to standardized practice. I'll just emphasize here that, hypertension is, given more priority in hearts. And then, but then, of course, they also pay more importance to CVD prevention. And it simplifies, procurement and also ensures efficient use of resources. And it also talks about the access to medicine and technology. So it encourages use of automated devices which are, standardized or compliant with specifications to ensure accuracy of measurement, like improving access to effective and affordable medications, etc. And the T stands for the team-based care. So it involves, working as a team. So ensuring use of non-physician healthcare workers, like primary healthcare workers at the community level. For example, outreach workers who can data and then who can screen for major cardiovascular disease risk factors like hypertension, diabetes, etc. Because all these are, as you all know, iceberg diseases, which means that what is really visible to us as clinicians in our OPD is very less, and a huge population exists out there which might be suffering from all these risk factors, but they might even be totally unaware of that. So that is where peripheral healthcare workers come in, and they can do the screening, and they can be a part of the team which manages the patients. And finally, the S stands for systems for monitoring. For example, ensuring blood pressure control as well as the data on medicine and equipment availability is collected. Okay, that is in a real-time basis, on a regular basis, maybe on a yearly basis, and all this is collated at the national level, and then this will help us to identify how much more resources can be put in, for managing or where to prioritize. And this will also give us, an idea about how to allocate the resources, where the need is there, where the lacunae is there, and how much given there based on the disease patterns. And also, putting in place programs and executing the programs and everything is kind of, useless if you don't have an idea of how well the program is working, and if you don't get the feedback of what else to improve and what else to manage or to strengthen, where things must be prioritized. If you don't have an idea of that, then there is really no point in collecting data or putting into place programs unless we receive the feedback. So therefore, monitoring is very important because it will kind of help us to manage and think where, and suppose something is not really working well, it will help us to manage and rethink our strategy and know where we are going wrong, and then try to fulfill or bridge that lacunae so that things can be put into place and it will achieve the objectives of what it was actually supposed to do. So that is where systems for monitoring is very important. So now mostly why I am emphasizing this point is because we see that even at the national level, there are very good systems in place. But then, the feedback loop or, monitoring is a lacunae. And if at all, even if, some lacunae is identified, there are no systems in place to kind of correct it right from the grassroots level. So again, this hearts emphasizes that point, of keeping in mind or putting into place systems for monitoring so that we really see in the real world if things are working. And again, hearts is important in the OPD. It is particularly relevant because it helps us to standardize care and to reduce clinical variation. For example, if we see a person today in our OPD and then tomorrow somebody else takes over, they must be able to understand the logic of what has been started and why it has been started. And of course, be able to improve the long-term outcomes by kind of, continuing or taking forward whatever has been started. And this is possible only if there are standard treatment protocols in place. Okay. And this means that treatment should not be based on the whims and fancies of every clinician who treats the patient. And also, the HEARTS integrates lifestyle counseling with medical management and, of course, uh, you know, tailored to the patient as such. But the thing is that there are standard treatment protocols as part of HEARTS, which clinicians should adopt, and then they can make it more consistent and therefore be able to take evidence-based decisions. And how is important it is that it helps in improving the continuity of care to a, and if at all a team is involved, like as I said earlier, for example, the peripheral health workers following up the people who are actually, been referred for some sort of management and who have received some intervention, let us say, counseling on lifestyle plus medications. The peripheral healthcare workers can also help in ensuring that, by doing periodic checks in the community and ensuring that all these measures are actually being followed. So this is a very, very, huge challenge, especially in a country like ours, like India, for example, because the population is huge, resources are limited, community healthcare workers are, again, stretched to the maximum. They actually have too much on your plate, I would say. So in situations like that, one more strategy is to involve, people from the family itself. So who can act as proxy, healthcare workers, in the sense that they can actually, simple measures can be introduced, like, having a glucometer in each household with a strip. This is what I'm saying is for, it might not be really applicable to the vast majority, but at least wherever feasible, because that much strain can be reduced on the healthcare systems, like, an automated BP apparatus. Now many of them have that, and creating awareness, among the family members who can actually act as, proxy workers, or at least, if nothing else is possible, to ensure that they follow the, advice which is given, and also, like, they maintain kind of linkage with the peripheral health workers, so that any problems, they at least feel confident enough to report to them, and then they can be referred to the primary health care's, you know OPD or something like that. So this is a very idealized situation, may not be practical, real, but this is something which I feel very strongly about as a community physician, and, somebody in community medicine. And actually, this is has been proven to, in certain other countries, to be effective, especially in, the Western world. But I would suggest that applying this strategy to our situations also can go on a long way in decreasing the financial burden or manpower shortage. So this is why, hearts, following something like a hearts approach makes preventive cardiology, or, cardiovascular disease prevention practical and achievable. Now, coming to the WHO CVD risk charts, we will have an overview of that. So now, these risk charts are one of the most practical tools for risk-based prevention. And these charts actually help to estimate a person's overall cardiovascular risk based on factors such as age, sex, blood pressure, the smoking status, and diabetes. So now, it actually estimates the absolute risk or absolute 10-year risk of a cardiovascular event. Either it can be a fatal or a non-fatal MI or even a stroke. There are two sets of charts available, which are non-lab based charts and lab-based charts. So these charts actually help to estimate, as I said, the overall cardiovascular risk based on certain factors. And what are they? As I mentioned earlier, it is like age, sex, BP, the smoking status, and diabetes. These are for the non-lab based charts. So the lab based charts will also add on the blood sugar levels and the cholesterol levels. So for clinicians, this supports more rational decision making and helps to prioritize patients who need more intensive interventions. So one thing I would like to stress here is that it identifies the overall risk and not, it does not really treat the isolated values. So, and just to briefly introduce the types of the charts. Now, the WHO has CVD risk charts for each, region. So India comes in South Asia, and the other countries along with in South Asia are Bangladesh, Bhutan, Nepal, and Pakistan, along with India. As far as Sri Lanka is concerned, Sri Lanka comes in the Southeast Asian region. So as far as people in Sri Lanka are concerned, the clinicians there have to utilize the Southeast Asian charts. And then I will just be talking about briefly about the non-lab charts, because in many of our primary healthcare settings, we really do not have facilities for assessing the cholesterol values. It's mostly a paid. It is expensive and it is mostly a paid service. So I'll just emphasize on the non-lab charts here. So here we can see that on the left side, there is stratification based on age. So this is mostly for people who are aged 40 and above. Okay, and then there are separate charts. Please follow the pointer. This is separate for men. And then there is a separate chart for women. And again, as far as men and women are concerned, there is a separate list for non-smokers and smokers here. And if you see the base of the chart, the body mass index levels are mentioned for both male and female. And on this side, on the right side, we have only the systolic blood pressure, which is mentioned here. So this actually we just take into account only the systolic blood pressure, and that is again for simplifying things. And actually these charts were standardized over by the WHO over specific regions. And that has been done after extensive, study, following up cohorts over years and years, and with a huge sample size which runs in lakhs. So again, the color boxes for this particular chart, okay, are that so the green is less than 5%, yellow for 5 to 10%, orange here from 10 to 20, and then the light red and the dark red. The dark red is very high percentage, that is above 30%, and the light red is somewhere between 20 to 30%. So this pattern is applicable for the Indian population, because this is because our population, the Indian population, is very much vulnerable for diabetes, and we have more propensity for cardiovascular diseases. So Keeping in mind all these risk factors, have been calculated, and a cumulative score or an estimate or the absolute risk for a 10-year risk of the cardiovascular event has been put forward. Okay, and the numbers in the boxes actually give that risk percentage. So when do we use it and how to use? So I have actually mentioned that in the previous, slide. So this is just to reinforce. And please remember that it is only suitable for adults without established cardiovascular diseases. Suppose a person already has had cardiovascular event like, a myocardial infarction or a stroke, or if they have some other, add-on risk factors, like maybe there might be a case of, chronic renal failure. All this will automatically put them into the high risk category. You really don't need to, assess the risk because they are already in the high risk category. So there is no option but to proceed with, therapeutic management, and the follow-up will differ for them compared to, an asymptomatic patient who has these few risk factors and who has not been really having an event, who has not have had an event so far. So this is, suitable for such adults only, and not for established CVD patients, is what I'm trying to say. So again, let us say we have interpreted risk. Okay. So it helps us to stratify and standardize care. For instance, low risk, suppose the person falls into the low risk, then we can treat them using you can just give them lifestyle advice and periodic review. And for moderate risk, we can give them lifestyle counseling and maybe closer monitoring and intervention if required using drugs. And high risk patients would be needing intensive risk factor management and referral to a specialist. So the key principle here is that the intensity of intervention should match the level of risk. And that is one of the success of the charts, because I would say they kind of, give us a standard mode of intervention or like a protocol which we should follow to match the level of risk for that person, so that they, during non non-cardiovascular uh, uh, symptom screening, um, this intervention can be prioritized. And even though the person does not come to us for, with signs or symptoms of cardiovascular disease, we can actually pick up the high risk cases and manage them accordingly before they land up with an active event. So coming to the next part, which is identifying risk is, useful only if it leads to action. And that's where counseling comes into play. So please remember that effective counseling does not require long sessions. Even short, focused interventions can influence patient behavior when they are clear, relevant, and when they show empathy. So here again, the goal is not perfection, but actually progress. That is, we encourage small, achievable changes that the patient can sustain over time. So even 2-3 minutes of our time spent in counseling patients can influence the behavior, and we just need to focus on one key message and one achievable practical change with the patient can relate to, and then give them small, small steps or small targets which they can achieve. And during follow, we can actually build it up. So which brings us to the 5A model, which provides a simple structured approach to brief counseling. So here we begin by asking about risk behaviors, then advising them clearly based on that, and then assess if they are ready to change, and then assist them with practical strategies and arrange for follow-up. For example, um, let us say we encounter a patient who is a male who is 35 years of age who just presents to us for some other unrelated complaint, and then we come to know that he is a smoker. All right. So we don't leave him as such. We just ask about other risk factors, like family history of diabetes, hypertension, his physical activity levels, whether he's a sedentary person or whether he follows, an active lifestyle. And then we ask him if, he or she has, any other risk factors, like whether he has or she has been checked up for hypertension or diabetes in the past, and what were the values then. And then, of course, we will ask him or her about any other addictions or something like that. And then once we come to know, so that is the ask part. Then we advise them regarding, how to change based on the risk factors. The assess part is we are going to assess if they are willing to change. For example, in this example I gave you, whether this patient, this middle-aged patient is really okay and who with stopping his smoking habit. So that is the assess part. And then assisting him. So we offer, the range of options, okay, the steps he can take to come out of his habit. And then we arrange for a follow-up, or we arrange for, referral to a specialist. For example, to any cessation, tobacco cessation clinics, if you have that, or if not, or if the patient, let us say, is an established, long-term alcohol consumer, for example, and then he has made several attempts in the past, and couldn't, handle it because of withdrawal symptoms, then we arrange for specialist referral care so that, they can have medical intervention and, assisted him to have specialist treatment so that they might be, more success this time around when he tries to quit. So this is the ask, that is identifying risk behavior, advice, to give clear personalized advice, assessing the willingness to change, assisting to help set a realistic goal, and arrange for a follow-up or referral. So this is this 5-way strategy. Now we come to linking clinical care to community follow-up. So please remember that preventive care cannot end with the clinical encounter alone. So for prevention to be effective, it should extend beyond consultation and continue over time. Because here, because we are giving more importance to NCDs for this talk, I would say that community linkage is important because long-term follow-up is needed for NCDs, which, might not always be possible by the clinician. And because it is not a one-time treatment, and it is a matter of long-term monitoring and following the advice or whatever intervention which has been suggested by the clinician. Same way, lifestyle modification, it is just a one-time advice which the clinician gives. See, people, we often say that people start off on their lifestyle modification journey, including me. So, we start off very well. We set targets for ourselves. We want to lose weight. We try to modify our diet. And, it is not lack of, motivation or anything, but the sustainability and the fact that we, as humans, we kind of lose, interest, or we become less focused once there is no reinforcement. So this is where, as I said, linkage to the community follow-up becomes important because there needs reinforcement beyond the clinic. And also, it's a proven strategy that community-based follow-up proves the adherence, the continuity of care, and the long-term outcomes. So, how do we strengthen community care or continuity of care in the community? So, from a preventive perspective, continuity transforms one-time advice into sustained action. As I said before, regular follow-up helps us to prevent complications. And once the team is involved, like the peripheral healthcare workers are involved, so a team-based care reduces burden on individual clinicians. So the follow-up part, the monitoring part, the encouraging part, all can be done by peripheral healthcare workers. And also, if there is a system in place for clear referral pathways, then we can ensure that the monitoring of risk factors is seamless and also reinforcement of lifestyle advice happens so that there is sustained action. In other words, good outcomes depend on what happens after the consultation. The consultation part is definitely important. I don't deny that. But outcomes, how much can be done will mostly depend on the patient and his or her environment, including the family and also the community, healthcare workers. So, which moves on to the next aspect, which is digital health for preventive care. Of course, digital tools offer additional support for continuity of preventive care. For example, telemedicine, mobile health applications, and digital NCD platforms can help with follow-up, reminders, patient education, and monitoring, particularly when the patient has no access to specialist care or when, let us say, in-person visits are limited. So definitely, when used appropriately, digital tools do not replace clinical care, but they definitely enhance reach and reinforce messages and support long-term management. So this might be a challenge in the current situation in resource-limited settings, but once systems are in place, I would say that they save a lot of time and money and also meet manpower resources. For example, to continue with the previous example, let us say, the person whom we have advised for, uh, tobacco or alcohol cessation is having a hard time, coping up, with the withdrawal symptoms, or there are too many cravings, or she feels that, they're finding it difficult. And then if they are in one particular situation or in a place where access to us, a good counselor or, or specialist clinics which offer counseling services are limited. Suppose, they can have a consultation by, teleconsultation means, then of course, access will become, so much more easier for such type of people. So a practical aspect I would suggest would be to gather people and give them an appointment, and then of course have a linkage to the specialist center or the higher medical care center, and then have a consultation in one go. So that will save so much of time, resources, as well as address the healthcare and manpower shortage, which we actually have. So coming to the last few minutes, I will just give you a case scenario so that we can kind of apply the concepts. Let us say if there is a 52-year-old male who attends OPD for a minor complaint, let us say gastritis, okay? And we monitor the patient and take his, measurements. The PP shows 150 over 94, BMI is 29, and he's a smoker, and of course, a 52-year-old male. So, how can a public health oriented clinical approach improve his outcome? Please remember that he has not complained of any cardiovascular problems so far. So to apply the public health approach, first, as I said, we screen him for the BP, BMI, and the smoking status. Next is we assess the WHO, we assess him using the WHO CVD risks chart. And to make it practical, I can just go back to the slide let me just pull this out. Okay, so as I said, it is a male. Let us say he's from my state, which is Puducherry. So I choose this chart for South Asia, Indian chart, and then it's a male, so I stick to the men chart, and 52 years. So I select this part, okay, and it's a smoker, so it comes to this block. I said that the systolic BP was around 150, which means that he would be somewhere here, and the BMI is around 29. So this would fall around this, right? 29. So here, and the systolic BP was 150. So here. So now we come to this box which I pointed, which is 12. Now, how is this really going to be effective? So if I have the chart in my hand, see, I can have a talking point, the red color, and then you can tell him that, this is your risk level. So you can really show the patient that this is where he falls, and then we can tailor our advice using the 5A method, which I told, which is ask, advise, assess, assist, and arrange. So the practical advantage, if you see, for using a colored wrist chart like this is that at least it gives the patient, rather than telling him, your risk is so and so, or this is dangerous or something like that, you can always tell him, see, if 12 people, or let us say if 100 people are there, who have the same, risk factors or the same age like you, who is also a smoker and who is having a slightly elevated BP, and who is overweight with an increased BMI. So if 100 people like you are there, then please see that 12 of you are at risk of having a fatal or a non-fatal heart attack risk, or you might even be ending up with a stroke over the next 10 years. So it will put things into practical perspective for the patients and make it easier to understand. And maybe in developed countries, they have CVD risk charts or scorings for each patient. But then in our resource constraints settings, I think each clinician can have a colored chart which they can kind of use to assess. And we saw it, right? It hardly took us 1 minute or so. So even in busy OPDs, we can have a risk assessment and then counsel the patient accordingly. So now that I have demonstrated practically that it takes very less time, we will move on to the key take-home messages. So, yes. The first point here again is that prevention can be integrated into every clinical encounter. Opportunistic screening identifies risk early. WHO tools make preventive care simple and practical. See, in India, one thing I would like to say is, even though I keep on talking about WHO tools, India has kind of taken all these concepts and then we don't follow the tools exactly, but at least in our primary healthcare setup, we have tailored it to suit our scenario, our population, and keeping the core of these tools intact. We have formulated our own guidelines. I'm sure Sri Lanka will also have something like that. Um, so, and also, one more thing I would like to say is that brief counseling can influence long-term behavior. At least, if anything, nothing else, we have to ask about the risk factors and assess if they are willing, and keep the advice limited to one achievable target for short term, and then keep following them up over time. So continuity of care is essential for sustainable outcomes. So a simple practical workflow would be to screen, educate, counsel, connect, and follow up. So this is the crux of today's talk, and this can be applied in any specialty and requires minimal additional time and improves quality of care and patients' outcomes. So now again, if you ask me what is the relevance as a take-home message, if I would say that all these fit together because the steps actually measures the population risk and helps us to prioritize where to give in more, resources and what to uh, give more attention to. The PEN defines essential clinical care, the PEN package. The HEARTS package tells us how to improve quality and consistency, especially for hypertension and CVD. And the risk charts, of course, will prioritize who needs the treatment most, and it will help us to identify people who are, at risk of events, but who are not having any symptoms or, the problems currently. So it will help us to pick up high risk individuals and then manage them appropriately. And all these together, they form a complete NCD controlled ecosystem. And another one thing is you can ask me which of the following is most important. I would say they actually kind of control the loop, because steps without pen is just having data without doing anything about it. And following the pen blindly without any hearts is kind of giving them care without any quality systems in place, or and then following the hearts again without the risk charts is kind of inefficient care, because people are likely to be missed. So the WHO steps tell us how big the problem is, the pen tells us what care to give, hearts tell us how to give it well, and CVD risk charts tell us whom to prioritize. So I would invite all of you to have a reflection or a self-assessment as to what is one preventive action you can start from tomorrow onwards. Because I was told that all of you, I mean, at least most of the audience is consisting of, primary healthcare physicians who are actually at the graduate level, and mostly primary healthcare physicians. So that is why I invite you to just think about yourself and to reflect what is one prevention action you can start in your busy OPDs, and which WHO tool will be most useful in your practice, and how can you strengthen follow-up in your own OPD, in your places where you're posted in the districts where you are. And please remember that, even though I've been harping about prevention a lot, I would really like to emphasize again that, catching people where it is important and preventing events will go a long way, especially in resource constrained settings like ours. So now I am open to any questions that you might have. Thank you.
So, thank you very much, Dr. Jyothi Vasudevan, for that very comprehensive lecture. So we have received multiple questions. Majority of them has been answered during the session. So I will pick up a few of the questions which might need a bit more focus. So one of the questions that were directed to us were, how can busy clinicians realistically integrate population level prevention strategies into short outpatient consultations without compromising the individual patient care? So I think that is what we discussed as a whole in the
Yes.
lecture. So anything that you wish to add to that?
Actually, as far as population level, okay, am I clear? Is the, video okay, or shall I turn it off?
That's okay. You're clear, and we can see slides.
I'm clear.
No issue.
Okay. All right. So the question asked, if I, understood correctly, was that knowing the population level strategies, how the clinicians can, how is it is going to help the clinicians? Am I right?
Yes. So how it can be realistically integrated to that small time period?
Okay.
Yeah.
Right. So one practical demo I had given you, like for example, our population, the Indian population, as I said, um, is very much, especially the place where I am in right now, that is in South India. I come from Kerala, but I work in a place called Pondicherry, which has, so much incidence of diabetes. Okay, and it is well above the national average, and everybody, who is here, most of my colleagues, actually, we are trained to kind of automatically assess the CVD risk of patients, even if they come for, kind of unrelated uh, complaints. So what happens is, when the patient comes, like, we have a huge caseload, to be frank. So what happens is that, in our department, there is, where we work, we are assigned small areas for, or we adopt that areas, and then we have, peripheral health workers who kind of screen that population. So that itself will, give us a high yield of patients, so that, such undetected cases can be picked up. And then we maintain a family folder for each family. And once they come to the, OPD, we just pick up that particular folder. So from there itself, because the base level or groundwork has been done by the peripheral healthcare workers, we, just by looking at the profile of that family or of that patient, because everybody in that family is kind of covered in that folder. So we have a separate, folder for each family, and in that there are specific, leaflets, outlining the characteristics of each member of that family. So by seeing that itself, I can have, an idea of the patient profile of that patient, and of course, screening in the patient of the patient in that day, like, is done by the nurses who take their BP. They calculate the height, weight, and they give me a kind of BMI, which is already there. So I don't really have to waste time in taking these measurements. These two things actually save a lot of time. And then we actually have the same folder, and anything I write in, uh, will be, we don't really give that folder to the patients because that can be missed actually. And we maintain or we have it in our center itself. So the minute anything comes in follow-up, or even if I leave or quit my job, then the subsequent person can have an idea of what I have done for the patient. And again, that person need not spend time in taking a rehistory or trying to understand what has been done, because patients here usually they come with they kind of lose prescriptions, or they really are not very careful with the medical records, unlike in the West. So another thing what our hospital tries to do is we kind of try to digitalize the uh, the treatment and all that, and we follow certain protocols so that everyone who treats a patient gives the same standard of care, and our protocols are all uniform, and we have a kind of it's there in, and we are trained that way. So that is one, and it's kind of integrated into our clinical practice that way. So that is, again, I don't have to break my head thinking what else or is what I'm doing is right. No, because the protocols are already there. All we have to do is kind of follow that. So again, that is a very important time saver. And then I also then the drugs. So which is again there, availability is there, and so the minute I prescribe, it is kind of standardized again, the standard of care, so that suppose tomorrow somebody else comes, then they can immediately leave off, they can get an idea of what actually has been done. So again, we don't have to kind of rethink and need to, redo the strategy the whole, starting from the beginning for that patient. So that is a very much a time saver. And counseling again, that is again mostly, of course, we give a one-time counseling, but then we don't go into too much depth. So for that, we our postgraduates, they give counseling. We actually train them, and they also, if suppose somebody is really obese, or who really needs dietary modifications, who has very high cholesterol levels, so for that only we actually refer them to those specialists, and then they take over, like the nutritionist or the dietary advisor, counselor. And weekly once we have a cessation where the psychiatrist specialists, they come, and then they help to manage such cases. So we collect them and then we refer them. So what I'm trying to say is, by involving the team as a whole, and of course, the follow-up again, which I was stressing about, again, we send them back, and then we intimate the peripheral healthcare workers who are assigned to that family, and we tell them that this is what has been done, and further follow-up, or whether compliance, etc., adherence is actually taken over by the peripheral healthcare workers. So this, what I'm saying is, it's an ideal situation for our college, because where I work in, the medical college that I work in, we have a good strength. But then this again, in the government setup, because I work in a private medical college, it in a government setup, again, this might not always be feasible, but at least record keeping can be actually maintained. And then, of course, putting into place protocols and talking to the people with practical aspects, showing them, proofs, like, which they can relate to. For example, that red color definitely would, I am sure, would have got that patient thinking, even though he or she might not be so much educated. So these are certain strategies which we follow in our college. But at least as far as practically in really resource constrained settings, what I would say is keeping into these protocols, training the healthcare workers as well as the medical officer, and also following up, a good follow-up need not be by the team as such, at least involving the patient's family. So all this can go in a long way uh, as far as addressing system shortages or poor resource settings are concerned.
Yes, Dr. Vasudevan. And then there's a misconception among the clinicians that these counseling sessions and introducing brief counseling, it takes a lot of time, and that is why they are very reluctant to start anything and thinking that it will cut into the clinic's time. So how can this health education and improving health literacy help in the long run to improve these patients, especially when it comes to preventive health?
Yes, as far as I told you, it's actually education of the clinicians. I think must or specialists must start from the way we train them as students. Correct me if I'm wrong, but this is my personal opinion. A sudden change cannot be brought in overnight. For example, uh, there's a misconception that surgeons and even orthopedicians, they hardly talk about preventing CVDs, or they don't really focus on prevention. But this is another one category where a lot of improvements can happen, because this is where we can actually pick up uh, a lot of undiagnosed cases. No, that is why I said opportunistic screening. And this mindset of providing doing opportunistic screening when patients come to us for unrelated complaints must be inculcated right from the time when the clinicians are students. So I feel that once that part is not really emphasized, because now the current clinical trend is that they hardly really talk about prevention. And it is not just for people like as far as NCD people in NCDs are concerned. For example, even in cases like antenatal uh, care. Okay, I would say really the incidence of GDM, or gestational diabetes mellitus, is increasing so much. So even those people really need to have a focus, and they need to be aware of such problems, and they need to be really trained to talk about this problem right at the onset of uh, you know when the patients come, actually. So for example, I can say from my personal experience that there are if, I have 6 or 7 colleagues, and I have female colleagues who are in the reproductive age and who have had born a child over the past 6 years, all of them. And 5 of them actually were diagnosed with GDM. So it's a global concern in the sense that our lifestyle is like totally changing, and GDM cases were very rare when I was actually training, but it is very much relevant, uh, you know, uh, like to have incidents of NCDs even in unrelated specialties. That is what I'm trying to say. So it is not something which clinicians can totally ignore, saying that it is not my problem, because it is definitely a problem, and it is definitely everyone's problem. Because an uncontrolled diabetic patient will pose a problem for the operating surgeons. Uh, you know, Severe hypertension, uncontrolled hypertension will definitely pose a challenge for the surgeons as well as the anesthetists during the surgery. So there, you really can't ignore these problems, saying that it is not my job. So talking about prevention, talking about holistic approach to the patient is very, very much essential, no matter who it is, no matter which specialty they belong to.
Yes, and also Dr. Vasudevan, especially when it comes to this type of a new initiative. So how could we ensure maximum public support, especially when it's cutting into clinic time, and whether we can utilize this time for the health education of the patients during the waiting times? And you talked about new initiatives with mobile and digital era. So how can we get their support?
So as far as the public is concerned, I think good thing is that, awareness is definitely much higher compared to what it was before. And you have raised a very valid point that, waiting times can be offered, uh, to give health education to the families as well as the general public. And here, and one more thing I would like to emphasize is, even this concept is definitely being put forward even in cases like ANC clinics. So they follow something which is called as group antenatal care. So the pregnant ladies, along with their mother-in-law or husband or whoever is coming to accompany the pregnant ladies for the antenatal visits, they are all gathered, um, and then they are given health education. It can be on any topic, maybe on their on how to have a healthy lifestyle, on how to modify the diet using low cost ingredients, and how to take care of the baby. It's like a group education session, and then the public also will feel that the time is not really wasted, because they would come, let us say, for a glucose tolerance test or something like that, and then they would be there in the clinic, waiting for the results or waiting to see the doctor, something like that, and then the time they spend there can thus be utilized effectively. So you might wonder why I'm stressing on antenatal care, because this is one group of people who are kind of, we don't pay too much attention to them as far as NCDs are concerned, because we think that they are kind of protected. So that is why I talked about the gestational diabetes mellitus incidence, which is really increasing these days. So in scenarios like that, as you very rightly pointed out, we can have these health education sessions in person, and that has been shown to have more of an impact rather than delivering just generalized messages over phone or even through the TV or something like that. More than that, these things like this will have an impact, and also involving the family members or the general public will again pay more dividends, because at least when the next time, or if they come, like let us say if a neighbor is accompanying an antenatal woman, so he or she is going to be listening to the talk, and then if somebody else in their family becomes pregnant or something, so with this knowledge they can help out those persons too. So that is why involving family members and the public is also very important.
So thank you very much, Madam, for that very intriguing lecture. And I think we have come to the end of the discussion today because of the limitations of time. So I would like to take my opportunity now to thank Dr. Jyothi Vasudevan, who is the Associate Professor of the Department of the Community Medicine of the Mahatma Gandhi Medical College and Research Institute of Sri Balaji Vidyapith University, Pondicherry from India. So joining straight from India for her excellent lecture and the precious time. And we really hope that she will continue to join with us with many more interesting subjects and topics with discussions in the future as well, madam. We wish you a very nice day and also a very happy new year.